Ma'am, we are on live and we are starting the session, ma'am.
Yeah.
Yeah, very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's webinar. The topic for today's webinar is PCOS and infertility. I welcome all the participants and I request them to post their queries, if any, in the chat box so that we can have a short Q&A session at the end of this presentation. Now it's time to introduce our invited speaker for the day, Dr. Bharati Morey, ma'am. Madam is currently the medical director and consultant in OBGYN. Saguntala Women's Hospital and Fertility Center, Navi Mumbai. And Madam has a very vast experience of 25 years of experience. Madam is the Chief Program Coordinator for Foxy Recognized Coloscopy Training Center, member Foxy Oncology Committee, past President Navi Mumbai Obstetric and Gynecologic Society, 2013 to 15. Madam is also the Chapter Secretary of Indian Menopause Society, Navi Mumbai Chapter, organizing chairperson of the 28th All Maharashtra Obstetric and Gynecology Society Conference held at Navi Mumbai, medical director at Rotary Club for Navi Mumbai, Garima with all women's member. Madam is also very keen interesting in conducting adolescent health programs all over the Navi Mumbai schools. So with this short introduction, I welcome you, ma'am. I'm handing session to you for your presentation, ma'am. Welcome, ma'am.
Thanks for those words. I'm audible, right, sir?
Yes, ma'am. Yes, ma'am. Very much.
Yeah. So today's topic for discussion is PCOS and infertility. Very important, very day-to-day practice topic, which I think very important to discuss. If you're in the OPD, suppose on an average we see 20 patients per day, and you're going to have at least 1 or 2 patients per session, that is morning 1 or 2 and evening 1, that the mother comes with the daughter and she says, madam dekho na mahina nahi aata hai barabar, do mahina nahi aa raha hai, aur wajan badhte hi ja raha hai. You can see that the daughter is 80 kgs and the mother is 55 maintained. Okay, so this is the scenario that we see, and hence the importance of PCOS. 1 minute, I have to.
And you can click on the slide, ma'am, and just.
Yeah. 1 minute. Yeah. So what is PCOS? PCOS, as it stands, polycystic ovary syndrome, which is also known as PCOD, most common endocrine disorder affecting the women of age. As I rightly told you in the OPD, at least 1 or 2 per day we will see the patients. The daughter is brought, or the daughter-in-law is brought by the mother-in-law. कि 3 साल हुए शादी को, बच्चा नहीं है, मैडम महीना भी नहीं आ रहा है सही. So women who have PCOS, they produce slightly higher amount of testosterone and other androgen hormones. Now testosterone and androgen hormones are there in both male and female, but the FSH to LH ratio is always 2:1 in women. And when this ratio reverses, that is when the testosterone and the androgen hormone increase, the LH increases, then you see that you will see the picture of PCOS. And this happens mostly in reproductive age. So these elevated levels of PCOS, they contribute to the irregular or the absent menstrual periods, infertility, weight gain, acne, excess of hair on the face and body, and there could be baldness of the hair, like of the hair loss also will be there, and you'll see baldness. And these patients, they are definitely at a higher risk of developing health issues such as diabetes, and if not taken care in time, they can go for endometrium also. So it is not only important before marriage, after the marriage for reproduction, but even at the age of 40, 45, diabetes mellitus, which is a slow killer. India is, number 1 in this, and this is a slow killer, and then endometrium. What and why should we know about PCOS? Because, as I've told you, infertility, dysfunctional uterine bleeding, endometrial carcinoma, obesity, obstructive sleep apnea, type 2 diabetes, dyslipidemia, hypertension disorders, possibility cardiovascular diseases. Then you can see that there is a family history of sisters, mother and daughter, all close female relatives, they will be having this. All these people have a higher risk of PCO. And most important thing, why you should take care of this, because maybe she'll need a lifelong treatment and lifelong health care. Now, what is ovulatory dysfunction that occurs in PCO? You can see that the hypothalamus pituitary ovarian axis, the picture, it's self-explanatory. You can see this hypothalamus pituitary ovarian axis, where the hypothalamus secretes the gonadotropin releasing hormone, that's a GnRH, that acts on the pituitary, and then this will release LH and FSH. These in turn will act on the ovary and they will produce the estrogen and progesterone. Estrogen and progesterone, again, they have a negative feedback on the hypothalamus. And this is how the system of monthly ovulation is controlled. So what happens here, you will see that 40% female will have, which come with infertility. They'll have regular menstrual cycles of 22 to 35 days, despite of this irregularity, but they might have dysmenorrhea. Then you have definitely thyroid dysfunction, because these are hands in glove. PCOD, hypothyroidism, and hyperprolactinemia. These are, three friends, and they are always playing with themselves, ringa ringa roses, pocket full of roses. So whenever you suspect PCO or you diagnose PCO, you have to see for hypothyroidism and hyperprolactinemia, because it is hand in gloves that these things occur. What are the phenotypes of PCOS that you can see? The phenotypes of PCOS that you can see are that's phenotype 1 is A, B, C, and D, where you have hyperandrogenism and hirsutism, ovulatory dysfunction, and polycystic ovarian morphology. In phenotype A, you will see all three are present. That is acne and hyperandrogenism, ovulatory dysfunction, as well as polycystic ovarian morphology. Phenotype B, you will see that there is absence of polycystic ovarian morphology on sonography, but there is hyperandrogenism and ovulatory dysfunction present. Then phenotype C, you will see that ovulatory dysfunction is absent, but there is hyperandrogenism and hirsutism and PCOD morphology on sonography. Phenotype D, you will see that the hyperandrogenism and hirsutism is absent, but patient will have ovulatory dysfunction and, how do I go back now? Yeah. Phenotype D, you will see that hyperandrogenism and hirsutism is absent, but there is ovulatory dysfunction and polycystic ovarian morphology. The epidemiological link, that is, you will see that PCOD increases the risk of type 2 diabetes mellitus. It also increases the risk of GDM. Insulin resistance is definitely very high in almost 65 to 80% of the PCOD cases. And the 60% of GDM, that's the gestational diabetes mellitus patients, they're going to develop type 2 diabetes mellitus. So there is development of insulin resistance, which is seen. And over here, you will see that insulin is primarily responsible for controlling LH. Point 2, you can see that insulin mediates androgen production in theca cells. Insulin resistance coexists with PCOD. Again, this is hand in gloves with PCOD. Women with PCOS have decreased sensitivity to circulating insulin, irrespective of weight, thus suggesting that this insulin insensitivity is intrinsic, that is, they are best friends. Myo-inositol deficiency occurs, and this further increases the insulin resistance, and the ratio myo-inositol to D-chiroinositol, it alters. And again, insulin signaling is damaged in PCOD because of the myo-inositol deficiency, which occurs, and that triggers the insulin signaling. So diagnosis of PCO, clinically, first, when the patient comes with history of, she enters your clinic and you see her, a hefty girl, which is maybe 18 years, but her weight is more than 65. She's a healthy girl, and she sits in your consulting across you, and you just observe her, and you will see her upper lip. You will see excessive of hair. Then after examination, you might have a little bit of hirsutism on the chin also, and the hairline could be a little longer. Then that is on examination. On history, she'll give menstrual irregularity. there could be, madam, bar upper lip karna padta hai, or it could be on sonography, polycystic ovarian syndrome. Believe me, you have to exclude all other etiologies of hyperandrogenism. And then after excluding other etiologies, you can diagnose PCOS. You have the NIH criteria 1990, you have the Rotterdam criteria 2003, where 2 out of 3 are required, either menstrual irregularity, which is on history, hyperandrogenism, or polycystic ovarian morphology on sonography. The AS classification, that is 2006, where you have menstrual irregularity, hyperandrogenism, and sonography shows polycystic ovarian syndrome. All other etiologies excluded. Now, have diagnosed, like you have diagnosed that she's a pakka case of PCO, you do all the studies, you will do your investigations, you will do your proper history, the blood tests you will do, and then you are going to confirm your clinical diagnosis and then go ahead for the treatment strategy. What is the treatment strategy? Treatment strategy, you see that you have to do there's a hormonal imbalance, that is hyperandrogenism, and I told you FSH-LH, the ratio changes, rather it becomes ulta. Normally it is 2:1, and in this it becomes absolutely the other thing. There's a metabolic imbalance where you have insulin resistance and you have dyslipidemia. Because of this, you have oligomenorrhea or amenorrhea. Anovulation is definitely there. Acne, hirsutism, and acanthosis nigricans also can be seen. Impaired glucose tolerance and obesity. Ma'am, kitna diet karti hu, main bahut kam khana khati hu, par exercise bhi karti hu, par wajan kam hi nahi ho raha hai. That is what the patient says, and the mother also says, ma'am, bahut zyada wajan badh gaya, kuch bhi karo, kam hi nahi hota hai. So what all you have to see? You have to have insulin sensitizers, that's either metformin or pioglitazone, anti-androgens where spironolactone, sapropterin acetate, flutamide and finasteride, OCPs, oral contraceptives, where she has to not have babies also and at the same time regulate her menses, clomiphene citrate, which are the ovulation inducers when she wants to get pregnant. See, the management depends on what age the patient has come and what are her symptoms. Diagnosis has been made, but what does she require? Whether she needs only regularization of menses, or she needs the metabolic disruption that has to be taken care of, or she's interested in fertility. So depending on that, you are going to use your armamentarium. Cosmetic, if she comes, there are some patients who come only for cosmetic, especially the unmarried girls, then laser treatment, bariatric surgery, and acne therapy, where your skin friend is going to help you. And others, like where they need statins or LOD, that is ovarian drilling, laparoscopic ovarian drilling, required in very few selected PCOD cases. Believe me, friends, nowadays PCOD drilling is obsolete. You have to do an AMH before. You have to confirm what is the AMH before. Only in few selected cases, which we'll see, you have to do PCOD drilling, not otherwise advised. So anovulation is a failure to release the oocyte from a mature graphene follicle, usually manifests as irregularity in menstrual periods. And most of these women have oligomenorrhea. So either the days they go more than 35, or they are having amenorrhea for 2 to 3 months. So anovulation is definitely there. In stimulated cycles, you have to increase the length of, there's an increase in length of FSH window. So you have to increase, there are definitely number of follicles are going to be more. That is the whole problem with this. They have many eggs, but they are not properly developed. They are not mature enough to, ovulate in time. Mature follicle is not there, and therefore they might conceive, but they'll go in either missed abortions or they'll have bad obstetric history. And therefore, unless the metabolic disorder is taken care of, then only you should make them pregnant. Otherwise, they're going to have a BOH. So what investigations you need prior to ovulation induction? Investigations is a basic CBC, ESR, your basic blood groups, you're going to do your all the 3 H's, HIV, Australian antigen, and you're going to do the HCV. You're going to do TSH, that's thyroid function test, definitely. You're going to do obesity, fasting insulin, AMH, free testosterone. Of course, you're going to do transvaginal sonography for the AFC. What is the antral follicle count? What is the quality of the eggs? Are there 2 small, multiple small follicles? Because on day 2, day 3, there's a particular dimension that you need before you start induction. Okay. So day 2, you do your FSH, LH, prolactin. You might do serum estriol also. Tubal patency and husband's semen analysis are the basic things required before you do ovulation induction. Either you ask them timed intercourse or you go for an IUI. So what are the recommendations? The recommendations are ultrasound should not be used for diagnosis of PCOS in those with a gynecological age of less than 8 years. That means less than 8 years after menarche. So after menarche, you have to wait for 8 complete years. Like, before the marriage, unmarried girls, they come and they have this, on sonography, transabdominal sonography, you see a polycystic ovary or a multicystic ovary. You should not label them PCOS because it's normal and physiological that multifollicular ovaries are going to be there in this time period. So the threshold for PCOM should be revised regularly with advancing ultrasound technology, and age-specific cutoff values for PCOM should be defined. Transvaginal approach is preferred in diagnosis of PCOS with married women and unmarried girls who are sexually active with their consent, of course. So what are the probes that are used? Endovaginal ultrasound with 8 megahertz can be used where you see follicle number per ovary more than or equal to 20 and or the ovarian volume is more than 10 ml. So this is how you're going to diagnose PCO. Okay. In older technology, it was used that the threshold for PCOM was that ovarian volume was more than 10 ml on either of the ovary. In patients with irregular menstrual cycles and hyperandrogenism, ovarian ultrasound is not necessary for PCOS diagnosis. However, ultrasound will identify the complete PCOS phenotype. In transabdominal ultrasound reporting, best focused on ovarian volume with a threshold of more than 10 ml because with this approach with obese patients, it's difficult. What are the clear protocols that are recommended for reporting follicle number per ovary and ovarian volume on ultrasound? So the minimum reporting standards are what was the last menstrual period, transducer bandwidth frequency, approach, either it could be transabdominal or transvaginal, total follicle number per ovary measuring 2 to 9 mm, 3-dimension volume of the ovary. You have to report the endometrial thickness and the appearance of the 3-layer endometrial picture that you can see on the screen. Is there any other ovarian pathology or uterine pathology, ovarian cyst, corpus luteum, or dominant follicle, which is equal to or more than 10 mm? So there is a need for training how you do the transvaginal sonography with meticulous counting, and therefore the 3D probes are come in the way. Most important is that the serum AMH levels should be measured, definitely. And standardization of assays should be made because, AMH is going to change as per age and ethnicities. So what are the predictive markers for ovarian response? You have the AMH, which is if it is between 0.7 and 1.36, and the AFC, that's the antrum follicle count, is 5 to 7. It's a poor response. AMH is between 1.5 and 3.4 with the AFC 8 to 14. It's normal response. If the AMH is more than 3.5 and the AFC is more than 15, which occurs in PCO, it's going to be hyper response. So depending on this, depending on what is the age, depending on what is the response of that woman for previous stimulation, you are going to decide your induction protocol. So international evidence-based guidelines for the assessment and management of polycystic ovarian syndrome, P018, what it has to say. So what should be used? It is the recommendations say that letrozole should be considered as the first-line pharmacological treatment for ovulation induction in women with PCOS with anovulatory infertility, and no other infertility factors are there. When letrozole is not available, yes, then and then you can use clomiphene citrate for induction. And most important thing is, health professionals and women need to be aware that the risk of multiple pregnancy appears to be little less with letrozole as compared to clomiphene citrate. Why are we worried about PCO and IUI? Because PCO has more follicles. So that is where we prefer to do induction of ovulation and go for IVF in patients with PCO, because they have more number of follicles, and therefore if there are more than 3 follicles, dominant follicles which are seen, then we have to cancel the cycle for IUI, or we convert the IUI cycle into IVF. So the clomiphene citrate and metformin, believe me, metformin has to be given. I would suggest that at least 2 to 3 months before induction of ovulation. I say, in my words, priming of the ovaries has to be done. That is, the metabolic milieu interior of the ovary has to be changed and brought to normal before you go for ovulation induction. So clomiphene citrate could be used alone. I am not saying that it couldn't be, but to improve the ovulation rates, metformin should be used. Metformin alone or clomiphene citrate alone, better results are if you use both together, clomiphene citrate along with metformin for ovulation induction in women with PCOS or obese, that is BMI is more than 30 kg per meter square, with anovulatory infertility and no other infertility factors. So if metformin is being used for ovulation induction in women where the BMI is more than 30 kg per meter square, definitely your pregnancy rates, first of all, your ovulation rates, pregnancy rates, and live birth rates are going to increase. Clomiphene citrate used in combination with metformin definitely is going to increase your pregnancy rate. Now, metformin with gonadotropins in patients with CCR, that is resistance with CC, which, these patients undergoing ovulation induction, you have to use gonadotropins in addition with metformin. Then the rates of clinical pregnancy, live birth rate are increased and cancellation rates are reduced. In patients with PCOS who are undergoing assisted reproduction techniques, that is either IUI or IVF, metformin co-treatment definitely reduces the OHS's risk and increases the pregnancy rate. No evidence exists of reduced spontaneous abortion risk in women with PCOS who have undergone pre-gestational metformin treatment. That is the evidence what it says. And there is no evidence of increased risk of major anomalies in women with PCOS which use metformin during the treatment, also in the first trimester. There are people who continue metformin till 12 weeks. There are people who continue metformin till 34 weeks to avoid GDM. So at the end, what they say is adequately powered RCTs are needed to evaluate the efficacy of metformin treatment in different PCOS phenotypes. Now you go to individualized stimulation. Now remember one thing, whenever you think of ovulation induction, every patient is going to be different. You have to give a cafeteria approach. No 2 patients are same. You have many factors before you start even deciding the dose of gonadotropin. What is the age? What is the BMI? Whether it is PCOS? What is the previous history of OHSs or high response? Very important. So what should be used? FSH, urinary FSH, recombinant HMG, or recombinant FSH. All are welcome, but what is the cost? Is it cost effective? Can your patient afford? The number of injections required? How many times she has to prick herself? What is the risk of OHSs? And many more. So you have to really individualize and tailor-made the decision. Urinary or recombinant FSH, anything can be used in women with PCOS depending on how much your patient can spend, who undergo controlled ovarian hyperstimulation. Okay, so it's not that you use either urinary or it is recombinant. Either of them can be used. Both have equal effect. What are the recommendations? The recommendations they suggest gonadotropins could be used as second-line pharmacological agents in women with PCOS or failed first-line ovulation induction with oral therapy of ovulating agents. And they should be definitely anovulatory, infertile. All other factors ruled out. Gonadotropins could be considered as the first-line treatment in the presence of ultrasonography monitoring, proper counseling of the cause, potential risk of multiple pregnancy in cases of PCO, where of course anovulation is the reason and other causes have been ruled out. Gonadotropins, if they're affordable, definitely they can be used in reference to CC combined with metformin therapy for ovulation induction, especially in PCO. Gonadotropins should be used in patients with clomiphene citrate resistance, definitely. You will see that there is increased clinical pregnancy rate. First of all, ovulation rate increases, increased clinical pregnancy rate, and increased live birth rates. Gonadotropins with addition of metformin could be used rather than gonadotropins alone in women with PCOS when anovulatory infertility. With CC resistance, all other causes ruled out. Now, either gonadotropins alone or laparoscopic ovarian surgery could be used in women with PCOS with anovulatory infertility, CC resistance, with no other infertility factors. After proper counseling, PCOD drilling is a dicey procedure. You have to counsel the patient very well, few selected cases, and there are strict criteria which will come in the slides coming forward. Where gonadotropins are prescribed, you have to see the cost, availability, the expertise required for using ovulation induction. You have to have a proper ultrasound monitoring. You have to have the proper preparations. No batch to batch differences should be there. Low dose gonadotropin protocols should optimize monofollicular development. That is, you can use for IUI. Risk and implications of potential multiple pregnancies should be kept in mind. Gonadotropin-induced ovulation is only triggered when there are fewer than 3 mature follicles, and these need to be cancelled. I've already shown this. If there are more than 2 mature follicles, if there are more than 3 follicles, you have to tell the patient not to have unprotected intercourse. That means she should not conceive in this cycle. Either you go for, you cancel the cycle, you tell them not to have a unprotected intercourse, or you convert it into talk to your IVF friend and go ahead with IVF cycle, where you can store the eggs and do the transfer, freeze them and do the transfer in the next cycle. This is a paper where to compare the effectiveness and safety of gonadotropins, hormones that regulate the reproductive system, as a second-line treatment to stimulate ovulation induction in women with PCOS who do not ovulate or conceive on CC, which we already discussed before. So what are the recommendations? Laparoscopic ovarian surgery could be the second-line therapy for women with PCOS, and it should be potentially offered as a first-line treatment if laparoscopy is indicated for any other reason in women with PCOD. Of course, the reason is anovulation for her infertility and other causes are ruled out. Risks need to be explained to the women who undergo LOD. Most important thing is that it could be comparatively cost-effective, but again, there is a risk of surgery. She has to undergo anesthesia. All the preoperative workup has to be done, especially in obese patients. And most important thing is that if the drilling is not done properly, in the proper way that has to be done, there is a risk of you lowering her ovarian reserve, or you responsible for her total loss of ovarian function. And there could be, if not done properly, you could land up with some periadnexal adhesions and there could be complications. So what are the protocols that are followed for ovulation induction? The protocols that are followed, that is CC 50 milligram twice a day or letrozole 2.5 milligram twice a day. You start on day 3, give it to day 7 for 5 days. This could be followed by either alone or with HMG or pure FSH. Again, FSH can be pure or urinary. HMG can be pure or urinary. Starting with small dose on day 3. And you can give progesterone also. What is the step 2 protocol? You have the CC or letrozole 2.5 milligram BD starting on day 3 to day 7. Along with that, HMG or FSH can be started from day 3 to day 8. Follicular study, you do a baseline sonography on day 2, day 3. Again, you do a follicular study on day 10. And you see that the follicle is growing at the rate of 2 mm per day. That is how you titrate your dose. And your endometrium is also growing properly. HCG trigger should be given when the lead follicle is 17 to 18 mm and then decide for your IUI, 24 to 36 to 40 hours after your HCG trigger has been given. Normally for IUI, you use only HCG for the triggers. Third protocol is you don't give daily gonadotropins, you give gonadotropins on alternate day, 3, 5, 7, and 9, overlapping with CC or letrozole. Sequentially, you start clonfin or letrozole day 3, 4, 5, 6, 7, and from day 8, continuously you're going to give gonadotropins, monitoring the patient on transvaginal sonography, see how the follicle is growing, and depending on that, you're going to increase or decrease the dose. So again, till the lead follicle is 17 to 18 mm, and then you give the trigger. This is the same picture diagram of the interrupted protocol of the GnRH that you give day 3, day 5, day 7, and day 9. Sequential protocol till the lead follicle is 18 mm. So there's another protocol where you have the group C PCO phenotype, which is grossly androgenized with hyperinsulinemia. Here, what I said is priming or the pre-treatment has to be given where change of lifestyle, you ask them to go for exercises, morning walk, vitamin D has an important role. So she has to walk in sunlight. Her, of course, general condition has to be taken care. You're already seeing her CBC, ESR, urine routine if there's an infection. And change of lifestyle. What is the change of lifestyle? If she goes by lift, you tell her to use the stair. If she's going by auto to the railway station, you ask her to walk down. You ask her to change her diet properly. Normally what we say is after sunset, no carbohydrates. It should be more of higher fish diet and no to junk food. Today, people work in ACs. They don't have time for morning walks and they eat junk food. It's all maida and maida. And in Marathi we say, tu tuja jivnacha shilpakar. Like you are responsible for your health, whatever you have created. OC pills can be given, ovarian drilling, which I've already showed, downregulation of the hormones along with ovulation, induction of gonadotropins, IUI or IVF. Now, 2-3 points about the LOD, that is the laparoscopic ovarian drilling, which I told you, the slides will follow. What selected few cases you can do where it is alternative to the expensive gonadotropins, which we can use and achieve unifollicular ovulation, reduce the risk of multiple pregnancy and OHSS. Intensive follicular monitoring is not required and therefore the cost effectiveness. So electrocautery, this is the green top guidelines by the RCOG, should be considered for selected anovulatory patients, especially those with a normal BMI, as an alternative to ovulation induction. You can see that this definitely should be used only in a selected few patients, only where they have thin limb patients, that is the BMI is normal, LH is more than 10. Here it is given, I'll just highlight it. Particularly LOD in selected few cases where hypersecretion as LH is more, normal body mass index, that's thin limb PCO, and maybe she can't afford gonadotropin therapy, and at the same time maybe she will not be able to come for regular transvaginal sonographies often. But LOD is valid but not the sole option for CC resistant PCOS. So how many punctures? Too little is insufficient, too much is harmful. So too much, too little, but just be right. So it is a rule of 4, not more than 40 watts, not for more than 4 seconds, and not more than 4 punctures. This is the rule of 4s, which most of us follow. This is the paper where the conclusion is adjusted diathermy dose based on ovarian volume for laparoscopic ovarian drilling of PCO syndrome is a better reproductive outcome compared to fixed thermal dose. So you have to always adjust, too little, not too less, not too more, adjust the right dose. So third line of treatment is IVF with ICSI, because with IUI, more than 3 mature follicles, and if we give HCG and go ahead with IUI, you're going to have multiple pregnancies, and you might have a triplet or a quadruplet or a pentuplet, and then you have to go for fetal reduction, which becomes an expensive work, right? So fetal reduction, and it's not available at all the metropolis. We in Mumbai are lucky, we can do that, but then that is again waste of money, waste of time, and too much of risk. So the third line of management, which is IVF or you go for ICSI, where women with PCO, more than 20 to 25 follicles with each ovary, anovulatory infertility, which is diagnosed, no other causes for infertility. This is the third line of treatment, which we doctors and of course the patients follow. So the recommendations are, now, most important thing now what they say is in vitro maturation can be used in patients with PCOS. That is the effective treatment for patients with PCO. So the term IVM, that is in vitro maturation, is applied when the maturation in vitro of immature cumulus oocyte complexes collected from antral follicles is encompassing both stimulated and unstimulated cycles, but without the use of HMG. So in this, what is done? Your eggs are picked up very much before, and the maturation is made in vitro, that is outside. So in women with PCOS, in vitro maturation is effective for improving fertility outcomes, is a question. And the maturation in vitro of immature cumulus oocyte complexes, which are collected from the antral follicles. So IVM could be offered to achieve pregnancy and live birth rates approaching those of standard IVF with or ICSI, so that you will not have risk of ovarian hyperstimulation syndrome. But there are 2 schools of thought. There might be some who would go for IVM, but most of us, what we follow is you do the ovulation induction, you pick up the oocytes, you vitrify them, then that is you freeze them, and then subsequent cycles you are going to thaw, and then you're going to transfer. This is the 3 musketeers, where you are not going to lose your eggs, you're going to have enough eggs, you're going to have good quality eggs. At the same time, there's not going to be OHSs for the woman, and you're going to freeze them. At the same time, you can transfer in the next cycle. So complication rate goes to 0, success rate steps up the ladder, and the pregnancy rate increases, the live birth rate increases, and take-home baby rate definitely increases. So now, evidence-based new approach with myo-inositol. In PCOS, myo-inositol also is used. What does myo-inositol do? it corrects that LH-FSH ratio by regulating the GnRH pulsatility. It improves insulin sensitivity by acting as a secondary messenger for insulin action in the peripheral tissues, and it brings down the levels of plasma insulin. Definitely, by all this, it improves ovulation, the quality of the oocyte, by acting as secondary messenger for FSH. So, in the beginning, we have seen all the various drugs which are going to be used. We have finished with CC, letrozole, gonadotropins. We have spoken about Bigomet, which is the king of treatment in PCO. Now we come down to myo-inositol. So the ratio MI-DCI 40:1, this ratio has to be maintained. And it is this ratio which is able to restore ovulation in PCO patients. So what is the take-home message? And that is why the role of myo-inositol. This 40:1 ratio has to be maintained, and then only you're going to have a proper ovulation. So what are the take-home messages? The comprehensive management of PCO requires patient-centered approach. That is, every patient is individual. You have to tailor-make your approach. Significant time dedicated to thorough education and counseling to the couple, not only the patient. There is a time lag which you have to explain to the patient. We are not magicians here. And you have to give them the update on newest advances in the literature. Improvement in health of the PCOS woman in pregnancy could help prevent disease in the next generation, that is the GDM, the big killer. In obese women, weight loss should be recommended prior to initiation of therapy. Before the initiation of therapy, I would advise to the patients, wait for at least 2-3 months. You know, there are few of us who are scared that the patient is going to go from us to somewhere else. And therefore, hurriedly, we go for induction of ovulation. Nahi baba, patient mere ko chhod ke kahin aur jayega. But if you have the significant time dedicated education and counseling with the couple, tell them that at now your quality of eggs is not good. You have to improve the quality of the eggs first and then go for ovulation induction. Then your success rate is going to be very high. So weight loss, change of lifestyle, take care of the hyperandrogenism, take care of your hyperinsulinemia. That is how your melee interior of the ovary is going to improve. That is how your, so there's a role of Bigomet, definitely. There's a role of myo-inositol, definitely. And then you go for ovulation induction with either oral first, which letrozole is the drug of choice, or you can do induction with gonadotropins. So that is very, very important. Thank you. I hope I've made your ideas clear. Then any questions? You're welcome.
Yeah, ma'am. Thank you, ma'am. Thank you very much for that one more wonderful detailed presentation, ma'am. It's always an honor to hear you, ma'am. Ma'am, let me wait for 1 or 2 minutes for the participants to post their queries, ma'am. If there is any queries, then I'll read it for you, ma'am.
Okay.
Ma'am, yeah,
shall
ma'am.
I stop screen share?
Yes, ma'am. You can stop sharing. Ma'am, in your presentation, you are talking about this bariatric surgery, ma'am. Whether this bariatric surgery really works in case of infertility treatment, ma'am?
Yeah, see, there are selected few patients. It's not on every patient. If you have a fast track treatment that you have to do. What I mean by fast track, the fast track cases which you have to solve. So when the patient is elderly, more than 35, okay, we have less time with us. She's already married for 3 to 4 years, and she's more than, her BMI is more than 35. She's tried everything for weight loss, which is not possible. In such cases, even at 30, if they are ready with the BMI 30, but more the criteria is 35, you should go for bariatric surgery with good hands, of course.
So, ma'am, how long they should wait, ma'am, after the surgery for getting this ovulation induction? Whether we can start immediately or we have to wait, ma'am?
No, I think you have to wait for at least 6
Yes.
weeks you have to wait. You have to get that consent from the bariatric surgeon,
Okay.
because they are more prone to infection. So you can't do it immediately.
Okay. Okay. Ma'am, and many doctors are using this DHEA for this ovulation induction, ma'am. Whether it can be used for this PCOS women as well, ma'am, DHEA.
So I feel DHEAS is more of for patients with poor ovarian response. I won't give DHEAS in these patients because testosterone is more in POR, this poor ovarian response, where her number of follicles is less than 5. AMH is somewhere like 0.5 to 0.75, and her ovaries are showing less follicles. I don't use in PCO. No.
Okay. Ma'am, what will be the advantages of using letrozole with clomiphene, ma'am? Whether it really works, ma'am? Like most of the doctors saying that clomiphene is a better choice for ovulation induction. So,
See, actually, if you see in PCO, why they say letrozole? Because PCO people have more eggs, right?
yes, ma'am.
So there are chances of twin pregnancy and multiple pregnancy as it is. So when you compare CC and letrozole, what they say is chances of multiple pregnancy is less with letrozole than with clomiphene. That is the most important point. Otherwise, and another thing is that in PCO, already your LH is high. So endometrial lining is going to be thick as it is, because the hormones are there. Clomiphene citrate does, it has the effect on the endometrium. It causes thinning of the endometrium.
Yes, ma'am.
So it is, acting against. So for all these things, so again, your endometrium is not going to grow properly and you're going to have implantation failures. So that is why letrozole is a better proposition than CC in PCO.
Okay. Participants, if you have any queries, you can just post in the chat box. If there is no queries, then we can end the webinar for today. So, ma'am, how many cycles of tetrazole can be tried, ma'am, in case of PCOS?
What they say is clomiphene citrate not more than 6. Or letrozole at the most you can go 4 cycles, not more than that. And already she's undergone clomiphene cycles, or 2 or 3, then not more than 2. Because you are somewhere what to say is impairing her capacity to ovulate.
Okay. Ma'am, there is no any other questions in the chat box, ma'am. So if you allow us, then we can end the webinar for today, ma'am.
Okay, thank you.
Thank you, ma'am. Thank you very much for
Thanks.
spending your valuable time with us today, ma'am. Thank you once again. And I also thank my Genisha team for making this webinar possible.
Thank you, Bharati madam.
Thank you, ma'am. Thank you very much.
Chaudhary, thank you.
It was really great, madam. And I'll meet you. Yeah.
Thank you.
Thank you, ma'am. Thank you, audience, for your active participation, ma'am. And we are looking for many more interesting webinars with you, ma'am. Please do support through our webinars, ma'am.
Thank you. Can I leave?
Thank you, ma'am.